Okay. So let's talk about foot and ankle, and we'll start with some imaging techniques and some anatomic variants. So we'll talk about technical areas, some anatomy, anomalies, and then we'll go into tendon, ligaments, bones, inflammation, and later in the year we might get around to masses, but probably not. Uh, so So here is an old coil, one of the first coils that was kind of designed for the foot and ankle so the toes could stick out like this. The coils are very important now. People mostly use flex coils to maximize technique. As far as techniques, there are a lot of techniques right now. It's important to use a small field of view. As you all know, we typically in the foot and ankle have two protocols. We have an ankle protocol, which usually does not include the base of the metatarsals, just the ankle and hind foot. And then we have a foot protocol, which typically has the toes and metacarpal bones in it. If you try to image the whole foot and ankle, then the resolution, I think, is insufficient to make some of the diagnoses we're going to talk about. So it's generally one of these two, and a lot of clinicians, if they're concerned about the whole foot and ankle, they'll get both studies. Typically, we use sagittal T1. I like to do a sagittal stir because that's a large field of view, often in the foot and ankle. If you are in the sagittal plane, you can get failure of fat suppression with PD fat sat, but RadNet's decided to do in the sagittal plane T1 and PD fat sats. And the coronal plane, we typically use a T1 or a T2 and a stir. And here at RadNet, you can do ideal if available, but most of our scanners don't have that kind of a technique, and so we normally don't use it. And then an axial T1 and a T2. And again, and the planes are very important here. I like to use the standard definition of planes. That's basically in the textbook. And if you stand with your arms down at your side and your palms in front of you, the plane that's parallel to the wall behind you is going to be the coronal plane. The plane that's parallel to the floor is going to be the axial plane. And the plane perpendicular to those two is going to be the sagittal plane. In the foot, it's an issue because then the short axis view for the long bones of the foot is actually the coronal plane, whereas in the rest of the body, the coronal plane is the long axis of the long bones. So that can be a little bit confusing, and a lot of radiologists will call the anatomically correct coronal plane the axial plane, which can be very confusing. So some people will just say short axis and long axis, and they're meaning with respect to the metatarsal bones in the foot and ankle. But just be aware of the potential of some miscommunication based upon the anatomy. And this is just showing some techniques. This was a Major League Baseball first baseman who had pain on dorsiflexion. And what we can see here is a T1 fat sat post-contrast study and a water ideal study. And here we can just see that there's with fat suppression, you get a lot of metal artifact from the metal. With the ideal technique, that's less. We can also get thinner contiguous slices with ideal. And here we can just see this subchondral cyst from an old injury here. Let's see. Oleg, what do you think of this particular case, this patient?
Oh,
The lesion that people were concerned about is this lesion.
oh. So there is a T1 hypointense and enhancing lesion.
Okay, so you say this lesion is enhancing?
Uh,
So the question here, so if it's enhancing, it means it's a solid mass, right?
yeah.
Okay. So the question is this mass enhancing? So let me show you what the T1 fat sat pre-image looked like. So this is the T1 fat set pre image,
Uh-huh.
and this is the T1 fat set post image.
Oh, you're saying that's not enhancing, so it's just
And you can see it's basically the same signal intensity that
so
you
it's
get
just
with
it's
noise.
just a fatty lesion, right? So
And just remember, for a lot of these cysts, they're going to have high protein content,
I
and they
see.
can be very bright when you fat suppress the T1s.
Mhm.
Even though you would think it would stay dark. And in this case, there was no enhancement, and this was a synovial cyst associated with degenerative disease of the first metatarsal phalangeal
I
joint.
see.
But the reason I come to this, there are probably most radiologists in the world, when they give contrast, they'll do something like a T1 pre and a T1 fat set post. And if you do that, you're going to overcall and make a lot of overcalls.
I see.
And this, you see it all day long if you look for it. So remember, whenever you give contrast in at least one good plane, you have to have the exact same T1 weighted pre and T1 weighted post. And usually we like them fat suppressed because you get better contrast. So you need a T1 weighted fat suppressed pre and post in the same plane. You don't need it in every plane. The one plane, so if you see something that looks like it's enhancing, you can go back to the plane where you have the pre and post and make sure that it's actually enhancing. So if guys have heard this over and over again, but I just want to continue to
I see.
emphasize it because it's a common mistake and commonly leads to misdiagnoses. And we already talked about the planes of the foot. Okay, Elior, what do you think of this case?
Okay, so you have axial,
It's a diabetic, and we're worried about osteomyelitis.
I see. Um, yeah, the first MTP joint, see some subchondral edema. I think I'd just call that degenerative change.
Okay, agree.
Are we looking at the soft tissues in the interdigit spaces there?
Okay.
Maybe there's edema on that T2 fat sat. On the T1, there's not much there.
And what do you think about the base of this second proximal phalanx?
On the T1, it looks
Looks
normal,
normal.
yeah.
So what would you do to try to figure this out?
Well, I mean, you'd look at it in other planes and maybe add contrast.
Okay.
Um,
How about a stir sequence?
Sure.
There's a stir sequence.
yeah, that looks normal.
So what happened? What is this?
Um, Maybe incomplete fat saturation.
Exactly. It's failure of fat set. And you see that all the time in the toes. And so this is something where you have to be careful. And that's why I really believe that even though in the toes we don't always do stirs, a stir can be a very valuable sequence to have in at least one plane because of the common failure of fat suppression in this area. So this clearly is normal, and that was just a technical problem. Resolution can be important. Here we can see there is a depressed fracture here, but with higher resolution, you can clearly see that there's a complete tear of the articular cartilage, and there is a depression here. So that's another reasons why you really do need to stick to small fields of view imaging in order to make sure that the resolution is adequate. There was a time when we would do a lot of arthrography in the foot and ankle. Pretty much have gotten away from doing any arthrography in the foot and ankle now. But anyway, so let's talk about anomalous anatomy. And there's a lot of anatomic variants in the foot and ankle, some of which can be confusing from a diagnostic standpoint. So it's a typical. So here's one. Robert, what do you think of this one?
All right, looking at the calcaneus, laterally looks like there's a protuberance kind of where the perineal tendons. Yeah,
Right.
exactly right there.
Right. So what's this called?
An don't know the name off the top
Right.
of my head.
Yeah. So this is called a perineal tubercle, and it's fairly common.
Mm.
The peroneus brevis goes in front of it. The peroneus longus goes behind it. This can produce, when you flex and extend the knee, it can cause rubbing of the peroneus longus against this fixed bony prominence. And as you'll see in a minute, what happens is it tense the peroneus longus tendon, which can cause irritation, tendinosis, and occasionally, eventually, a tear. Often it's associated with bone edema, and you can get symptoms both from the bone injury as well as the tendon injury in these patients. And this is what it looks like in the coronal plane. Okay. So now, what is often confusing, and I've seen even some very experienced radiologists confuse this, there is commonly a little projection posterior to the peroneus longus tendon here called the retrotrochlear eminence, which is a normal finding. In fact, there's a little ligament that attaches here, which probably causes traction to produce this. The peroneal tubercle is always separating the brevis from the longus. Okay. Tayson, what do you think's going on here? Never mind. Let me just show this. And this just shows you what sometimes people will call a peroneal tubercle. Notice it's posterior to the peroneus longus tendon in this location, and here's that ligament attached to it, retrotrochlear eminence. I've forgotten the name of this, but I think it's going to tell us right now. That's a peroneal retinaculum, which attaches to the bone in this location, and this is the retrotrochlear eminence, which is not considered a pathologic entity and is generally not associated with pain unless you have some injury to it. Normal anatomy. Okay. Oleg. Beautiful 0.2 Tesla images. Talk about great spatial resolution. So what's happening here? Patient has medial ankle pain.
Medial ankle pain.
Okay, so it's medial ankle pain. This is medial over here. This is lateral over there. This is the navicular, cuboid.
So there is
calcaneus.
like a accessory navicular or something.
Okay, good.
So it's like
So
a
you
type
see
2.
there's an
type,
ossicle here.
Yeah, okay, type 2.
This is actually the distal end of the posterior tibialis tendon, and that's accessory navicular. If we were type 2, I guess we're going to go through these now, even though we'll talk about it again when we get to tendons and talk about the PTT tendon. Elior, what do you think of this case? It's in a kid.
Yeah, so axial images, we're looking at the navicular again here, kind of has this kind of posteriorly projecting protuberance.
Okay, and this is the PTT coming in here, attaching to it.
Okay.
So what's this?
I think it's an os navicular type 3.
Yep. So that's a type 3. And I think we're going to go through the different types here. Okay, type 1 is basically small. It's embedded in the distal posterior tibialis tendon. Does not, usually it may or may not, but usually doesn't directly articulate with the navicular, typically around 2 to 3 millimeters. Type 2 is larger, also in the distal posterior tibialis tendon, but it often articulates on one side with the navicular, and that can become degenerated and produce symptoms of pain. And then the type 3 is just the prominent process where the PTT attaches. There are many ossicles which can be seen around the foot and ankle. I don't recommend memorizing all of these. Ones we see all the time, obviously, are the sesamoid bones. Some of these, most of these in books are thought to be congenital. Many of these, however, are acquired, as I think we've talked about. And ones that we'll really talk about are the os perineum, the ones that tend to be symptomatic, and the os trigonum back here, which are these are typically well, we'll talk about them. Some of these are acquired, and we'll talk about how we acquire them. Robert, what do you think of this? This is very tough. There's something here which actually is not normal anatomy. This is a bipartite first cuneiform. This is actually the first cuneiform, but you'd need all the images to really see that. Here's just another example where this is actually the medial, middle, lateral, and cuboid, and this just shows the division here within the medial cuneiform, and this is another bipartite cuneiform, which you can have, which probably is a congenital variant. And here's a CT scan showing the bipart cuneiform. Okay, see, who's next? Is it Robert? Robert, are you next?
Yeah, I think that's me.
Good.
Here looking at the posterior aspect of the talus, it looks like there's a sciatica process, elongated posterior.
Yeah. So this is a big one. When they're big like this, they can produce posterior impingement that we'll talk about later. The sciatica process is considered kind of a normal variant. Tayson, what do you think about this case?
Well, this one has a clear separation between this ossicle, so I'd say it's an os trigonum.
Right, so this is an os trigonum. We can see there's some edema here in the bone. These are classically described as being congenital in nature, though I've not seen a lot of these in kids. You see quite a few of them in adults. And I think that if you look at a lot of these, you'll find that the margins kind of fit very nicely with the posterior aspect of the talus. And it really looks like it fits nicely here. I think a lot of these, maybe not all of them, but a lot of these are old fractures of the sciatica process. When they're big like this, they can be associated with posterior impingement that we'll talk about later. We can see some degenerative changes here, the calcaneus and the posterior margin of the tibial plafond due to posterior impingement that we'll talk about later. Okay, Oleg.
It's
Okay, so this is the distal calcaneus. This is the cuboid. That's the base of the fifth.
okay. So it's then os perineum, no?
Yeah, I think this is os perineum.
Okay.
There are several other ossicles that have different names here, but I think that if it's within the peroneus longus tendon,
Okay.
it's really an os perineum. In this case, it probably articulates with the cuboid in this particular situation. Maybe a little bit of edema within it. And this is os perineus. Okay.
Okay, are we looking at the base of the fifth metatarsal here?
We're actually looking at this area right there. Now, let me tell you, you can't, this is a T1 weighted image, but this is not black. This should be a black line here. This should be an intact peroneus longus tendon, but there's a partial tear in it due to a recent injury.
Okay.
So you have to take my word for that. So this is, wait, let me say the date here. Oops. It's not telling me the date. Okay. Oh, here it is. So this is April of 2000. So now the patient comes back and May of 2004, so basically 4 years later, and the same area looks like this now.
So I think this ossicle is it an os perineum that's retracted, maybe?
It's an os perineum. And here and this, you can see that there was no os there before,
Okay.
just an injury. Then the os developed after the injury. Other areas where we commonly see ossicles are the ossicles of the ulnar collateral ligament of the elbow, present in about 15% of all Major League Baseball pitchers. If you look for other people in the world, they're extremely rare. What do Major League Baseball pitchers do commonly? They tear their ulnar collateral ligaments. So I think a lot of these, and there are other areas where we've been able to follow injuries and they've come back and we've seen ossicles develop. I think these often occur in areas where you have partial tears of a tendon or a ligament. And in the healing process, in some people, they'll have an ossification process occurring, which goes on to a mature ossicle within the tendon. So I think since the bulk of these occur in very characteristic locations, they tend to occur in locations where there is a high risk of injury to those structures. I think a large number of these ossicles within tendons and ligaments are actually post-traumatic and acquired. And also, we don't see them often in kids. Okay, Robert.
All right. It looks like there's an ossicle. Is that the cuboid?
Right. Yeah, and so it's coming right down, and this is right where the peroneus longus comes under here, right in through here. And we can see this is a mature ossicle. This is called peroneus bipartitus ossicle, but it's basically an ossicle in the tendon there. And here you can see it on the T1 weighted image. Okay, Tayson, ankle pain without known trauma.
All right, well, looks like a well-corticated ossicle inferior to the lateral malleolus.
Okay,
Um,
here's what the MR scan looks like.
is this an os fibulaire?
Okay, this is an os fibulare. Good, that's what it is. And what is an os fibulare?
I mean, if we're, discussing whether or not it's a post-traumatic, if it was post-traumatic, I guess an avulsion from that.
Yeah, I think the majority of these, and it really looks like it could come right from this location. I think the majority of these are old avulsion injuries at the attachment of the anterior talofibular ligament. I'm sure not all of them are, but commonly, I think that's the case, and you'll see very frequently. You'll see now a mature anterior talofibular ligament attached to the unstable ossicle and not to the base of the fibula.
Okay.
So again, the old debate of the old trauma versus congenital, and those are pretty common. Okay, Olive. Okay, so this is what we're worried about.
Yeah, no, is it like
You can see there's edema in the bone here. We can see there's a lot of edema in the cuboid.
um, it's like process of the calcaneus?
Okay, so actually this looks like going out to the anterior process of the calcaneus, but all of a sudden it gets truncated here, and we've got this ossicle here.
So what's the?
You can see it's pretty broad if you look at it in the coronal plane.
Oh,
And then this is anterior calcaneal ossicle. These are pretty common. Again, this is a situation where some of them may be congenital, but I think the majority are old fractures of the anterior process of the calcaneus, which we not infrequently will see as acute fractures.
mhm.
So it's another area where there's a common fracture, and if they don't heal, you can be left with an ossicle there, and that ossicle can grow. Okay. This is a CT scan in a different patient showing the same ossicle. It's also called an os calcaneus secundarius, if you want to memorize a lot of names. And yeah, and I think most of these are probably old fractures.
Mm-hmm.
Here's a plain film showing the same thing. Okay.
Okay, 37-year-old male, intermittent foot pain. Do we know which foot?
Look at that history, you know.
Are we looking kind of in the region of the base of the second metatarsal? Yeah. Mm,
How about a CT scan?
yeah, this kind of ossicle there on top of the second metatarsal base.
That's called an os intermetatarsal.
Okay.
And the cadaver studies are up to 12% of people. X-rays like 3%. So they're not uncommon. And I think most people just pass over them. Robert.
All right, so we have a 27-year-old with 1 year insidious onset pain. The only thing that stands out is that navicular bone is at an os navicularis.
Bring that in there. Okay. So we're looking at it here.
Mm-hmm.
Now, so here's what the MR scan shows. So I think that, you know, there's a lot of pathology there that could be a cause of symptoms, but it's just very difficult to see on plain films. And certainly here, don't say this is probably a little, maybe a type 3 accessory navicular. So the nice thing about MR scan is that we can see the bone edema, which is a pretty good marker for a cause of symptoms, but we can see that there's a prominent bony eminence here. So this patient probably presented with a palpable hard mass on the dorsal aspect of the hair with bone edema and so forth. And then this was a painful os intermetatarsum. So, and you can see there can be a lot of different locations, a lot of different figures here. I think it's very hard to work these up with just plain radiographs. I think CT is actually pretty difficult as well because you don't see the bone edema to see whether it's actually significant or not. So it's an area where MR can be very helpful. And this just shows the course of the nerves overlying the metatarsal basis where you can get some pain here and compression of the deep perineal nerve. Okay, I'm sorry. Who's next?
It's me.
Go for it.
I see a corticated ossicle inferior to the right medial malleolus. Congenital or post-traumatic?
So kind of see two things. So the top one is an os subtibialis. And I think most of these are dystrophic calcifications which ossify from injuries to the deep deltoid ligament. That's just my bias, as you guys can tell. And then the calcaneus secundarius, it could be due to trauma or Could be congenital. Okay. And here we bunch of other ossicles. And this is an os vesalius over here. And here you can see that it's actually going to the base of the fifth, and you can see some trauma to the bones here, which is why the patient was imaged, rather than following the course of the peroneus longus tendon. Okay.
Um, so like cuboid, like
So,
wait
so,
a second.
so
No,
this is the talus,
tails. I'm sorry. Yeah.
and
So
we got something here looks
some
like a
kind of
degenerated joint
so it's
articulation with the talus, right?
so it's again
This would be the medial side of the talus.
so it's again tails. Okay.
Okay, let's look at some other images.
Oh,
Patient
don't
has a
see
little bit
much.
of flat foot deformity here. And then we can see this. So what is this? Do you know what this structure is? That's the posterior subtalar joint space,
Okay.
or set. Here you can see it's kind of irregular there. And this is an ossicle right next to the posterior facet, medial ossicle. And a patient like this, another thing you have to worry about is whether this was an ossicle in this case, but what else would you worry about that might have this appearance that might be associated with pes planus?
Fracture? No.
Well, it could be a fibrous coalition.
Fibrous coalition.
And this is a common location for coalitions, but in this case, this was an ossicle and not another bone.
Medial ossicle.
Okay.
Okay, 5-year-old male. Yeah, so I see a flat foot deformity.
Yeah.
Yeah, I'm not.
And you can have kids. Okay. Let's go to another image.
Okay.
You didn't count all the metatarsals?
No. Okay.
That this guy had a broad foot deformity.
Let's see.
Okay, this is polydactyly. Okay, so let's talk about coalition. As you know, you can have fibrous coalitions or cartilaginous coalitions. Some people separate these two. Or it can be a bony coalition. This is where there is abnormal, either fibrous, cartilage, or bone binding through a joint that should be more freely movable, and that changes the forces throughout the entire rest of the ankle, and often leads to other deformities because of change in the force pattern through the bones. And typically, it's associated with marrow edema in the areas of high stress, which is associated with symptoms. So, Robert, what do you think of this case?
Here, looking posteriorly, it looks like there's a coalition of the talus and calcaneus.
Yeah. And again, this is a fibrous coalition. We can see irregular, low signal intensity, where you should have a nice, smooth bone underneath the cartilage. Here it becomes irregular. You often will get marginal osteophytes in this location due to the strain and the stress pattern, and typical bone edema on either side of it. And so this is a very typical fibrous dysplasia. And the subtalar joints are a common location for these conditions to occur. So, and often associated with tarsal tunnel syndrome. Okay, Tayson.
All right. So, looks like we have fibrous coalition between the navicular and is that the talus?
Okay, so we see a very irregular, what should be subchondral bone, and instead of having the normal, nice smooth cartilage here, we've got a lot of irregularity and tends to have more of fibrous signal intensity than you'd have with normal articular cartilage, and so this is another fibrous coalition. Good.
Anus. Okay.
Uh, Go ahead, Oleg.
Um, it's looks like, yeah, again a navicular
Navicular here.
and navicular and calcaneus, navicular again.
Okay, so calcaneus navicular. Again, we have this irregular
Yeah.
bone here
Hmm.
across there, and here we can see a lot of edema within the navicular there. So again, this has a very typical appearance of a fibrous coalition.
Hmm.
And this is a very common location for fibrous coalitions.
Okay, so here we see kind of a similar appearing coalition between is it the calcaneus and cuboid?
Uh, let's see, I think it's mostly navicular. If we can follow this all the way across here.
Oh, okay.
So it's really, instead of just the anterior process, it actually, you have a broad, or basically coalition between the distal calcaneus and the navicular all the way across, which is really unusual. Usually it's just on the lateral side, but this goes all the way across and was very symptomatic. This was a high school volleyball player. We can see the edema on the stir images in that location. And then, so the patient had surgery. They went in and basically got rid of the fibrous coalition all across there. We can remove the bone. And this was postoperatively, where you can see where they took out bone for this coalition. And then here's basically a talar-navicular coalition, where the talus and the navicular bony coalition in this patient. Why don't we stop here, and we'll finish coalitions and go on to some other lesions on Thursday. Okay? Great.
Thank you.
Thanks.
Excuse me?